are common neoplasms. Some are not so common, but they're very characteristic, so I put them on there. We actually had one of these in a ferret like a couple of months ago. So this is a ferret tail, tip of the tail. Does anyone know what this tumor is?
A cordon.
Oh wait, cordon. So do y'all know where this comes from? Where the name chordoma comes from?
The spinal cord?
Yeah. So the notochord. Yeah. So this is derived from the notochord. So it doesn't always have to be on the tip of the tail. It can be kind of anywhere along the vertebrae, the spinal column. But tip of tail is most common. Okay. So histologically, on this image, it's a perfect cross section. You have, can somebody tell me what organ this is? There's the normal right here, the skin. So this is what type of skin. Is it haired or non-haired? Haired. And I notice magnification is very low, but you should still be able to appreciate these structures here, which are your hair follicles, and these structures here, which are your sebaceous glands. So you only have sebaceous glands where you have haired skin. Okay, so haired skin with a big old tumor in the middle. And is this tumor compressive or infiltrative? Compressive. Yep. Sandtile, so it's a benign neoplasm. Okay, so we have a higher magnification. So this cell kind of has a distinct architecture where you'll have a central area of bone, and then you have these larger notochord-derived cells in the periphery, which are called physaliferous cells. And so these are large cells with abundant vacuolated cytoplasm. Here's another mag where you can kind of see the layers. So you have a central area of bone, and then the physaliferous cells at the periphery. Any questions on that? Chordoma. And it doesn't have to just be in ferrets. Other animals get them too. So this is a very uncommon tumor, but it's a very characteristic, not so much the growth, but the histology is very characteristic. Oh, yes, ma'am.
Did you say the physaliferous cells made up the chordoma?
Yes.
Okay.
These are this, like, this is this
Got
on
it.
how
Okay, it's magnetized.
Okay.
Okay.
Yes.
In the next picture, the multilobular tumor. My question is that brain compressed or there's like lack?
It's compressed. It's definitely compressed. So this tumor is actually benign, but it's very, very, very expansile and compressive. So yes, it was causing ventral deviation of the dorsal aspect of the cranium with significant compression of the brain. Like, how do these animals live this long? A lot of times they compensate, especially when you have something that's slow growing. It gives your body time to adapt. So you see some really crazy things sometimes. So multilobular tumor bone is just a benign tumor bone that can cause significant damage. And I put this up there because of this characteristic histology. Like nothing else looks like this. I've seen like maybe 1 or 2 cases of this as a resident. So you have this bone growth and fibrous tissue around it, and you just have these conjoined lobules of this repeated pattern. You'll probably never see it. It's so uncommon, but it's cool. I'll put it up there. Okay, so can anybody tell me what tumor you think this may be?
Osteosarcoma.
Anytime you see a tumor in the bone, just say osteosarcoma. That's probably what it is. So one of the things to know about osteosarcomas is they do not cross the joint. So if you see a tumor that's going from one leg to the next or within the joint space, even though it's a native bone, it's probably not an osteosarcoma. You have a variety of tumors that can affect the joint spaces and go into bone. What do you think? What would be the tumor cells that originate from the joint or the synovium? Yeah, you can have a chondrosarcoma, you can have a synovial cell sarcoma, you have a variant of histiocytic sarcoma called periarticular histiocytic sarcoma. So that's where your mind would go if it is crossing the joint. But if you see a tumor in the bone, this would be your first differential. And I want to point out, so this tumor probably started in the medulla. So this is probably a medullary osteosarcoma, and it grew out. And I always like to emphasize that because there are many times we get biopsy samples of the bone, but we don't see any tumor cells because they just simply did not go deep enough. And it's important to remember most osteosarcomas start in the bone marrow or the medullary region and grow out. So if you do a bone biopsy, you have to go deep and make sure you get into the medulla or you can just not have a diagnosis early. Okay. So histologically, osteosarcomas are defined by the presence of this pink material. And y'all know what this is called? By any chance? So, osteoid. Okay. So osteoblast, which is, so you can have an osteoblastic osteosarcoma or you can have an osteoclastic osteosarcoma. What's the difference histologically between osteoblast and osteoclast? Like what's the histological feature that you can see to say, oh, this is osteoclast?
They have like the little finger things, like they have those wavy things.
Yeah. So they sit on these, in these, what they're called, house shaped lacunae. But what about the cells themselves? So like here, they're multinucleated. So osteoclasts tend to be multinucleated where osteoblasts are not. So that's one of the features we'll look at to determine which type it is. Osteoblastic osteosarcomas are more aggressive than osteoclastic. Okay, but the main thing that you see to give you a diagnosis is the presence of osteoid. Yes.
Clarification, you said osteoclasts are more aggressive?
Less. Osteoblasts are more aggressive. Osteoblastic, which is the most common. Okay, and that produces osteoid. So here, hopefully from previous lectures, you can appreciate these are mesenchymal cells. They're kind of spindly, stellate. They're not really, cohesive like epithelial cells are. So this is a mesenchymal cell neoplasm. So you could always start with that, and then you look for other features to kind of drill you into what it is. And here with this eosinophilic material, it's obviously osteosarcoma. Okay, so osteosarcomas have site predilections. So have you heard about these already? So what is the like phrase we say? Away from the elbow and towards the knee. Good. So proximal humerus, distal radius, and distal femur and proximal tibia are your most common sites. Okay. A lot of times you just see a growth. It may or may not be painful. Usually initially it's not. And then radiographically, osteolysis is like all the alarms go off in your head if you do a radiograph and see this, because osteosarcomas are very osteolytic. And they call when you kind of have like a splattering of white, a starburst pattern. You can kind of see that maybe here. Not the best picture of that, but it is a great picture of osteolysis.
Dr. Gilbert?
Yes.
Even with osteoblastic tumors, you'll still see osteolysis
Yes.
on the radio?
Definitely.
Why is that?
Because it's an invasive neoplasm,
Okay.
so it's just invading, degrading, eating into whatever it can get its hands on. So it's about the aggressiveness of the neoplasm. Not so much because it's eating or engulfing, it's because it's an invasive neoplastic process.
So then the osteoblasts aren't necessarily building bone at the same time, they're just...
Well, they're laying down, they're depositing osteoid, but it's not going to be in an organized fashion.
Okay.
It's not like they're making bone. They're just secreting what they know to secrete, which is osteoid. And so it's just laid any kind of way. And sometimes you have a poorly differentiated tumor and you don't find a lot of osteoid. And then, of course, you do your immunohistochemistry to try to narrow down the cell of origin. Any other questions? Okay. So breed predilections, your giant and large breed dogs are much more likely to get osteosarcomas than small breed dogs, but it can happen in any animal. It has a high mortality rate. If you catch it before there is any evidence of regional lymph node metastasis, you increase the likelihood of, or the chance of survival, or the survival rate. And if you do catch it, even though maybe you just saw it on the distal limb, still, what's recommended is that you amputate that limb and you give chemotherapy because of the aggressive nature of this tumor. And sometimes metastasis still occurs. It was still in the vessel, we just didn't know it. So remember, the way I remember that sarcomas go into the blood vessels and carcinomas go into the lymph vessels is I think of the word hemangiosarcoma, which is a neoplasm of the blood vessel cells, endothelial cells. So if you remember hemangiosarcoma, just remember sarcomas go into the bloodstream. Okay? And then for epithelial tumors, they do the others, which is the lymphatic vessels. And a lot of times, what was I going to say? I don't know what I was going to say. But the lung is the most common site for metastasis of osteosarcoma. So anytime you have osteosarcoma case, you give it a guarded prognosis, even if it looks okay, and you say continual monitoring is recommended continual monitoring for distant metastasis is recommended, and I always tell them the lung is the most common site, so they'll know to keep doing radiographs of the lung. This is important. That alkaline phosphatase is a prognostic marker for osteosarcoma. So when you have osteosarcoma, if the ALP is elevated, I don't know exactly what that level of elevation is, but if it's elevated, you already have a bad prognosis, because it's been shown that animals with osteosarcoma with elevated ALP have a lower survival rate than animals with osteosarcoma without an elevated ALP, at least to a certain degree, but I don't know what that number is. So alkaline phosphatase, where do you see that? So the liver is one of those locations where it is. So you have a hepatic isoenzyme. What other isoenzymes do you have? Not other liver enzymes. What other isoenzymes of alkaline phosphatase do you have? One is hepatic. The other ones? Huh? You may not learn it yet. Oh. So I just said, y'all have come back?
No, next semester.
Yeah, see, I can do it. So you have a hepatic isoenzyme, a steroid or corticosteroid isoenzyme. So you can see elevated alkaline phosphatase with excessive glucocorticoids. You have the bone isoenzyme, which is why in growing animals, it's normal to have a high ALP or anything that's causing changes with the bone. And you have a intestinal isoenzyme. So alkaline phosphatase is not specific for the liver, but that's what you most commonly hear about it with gallbladder, with like cholestasis, but just know there are different forms, and you'll learn about all that later. But now you have an idea. All right, any questions on osteosarcomas? Okay. So, y'all know what organ this is, I'm sure. What is this structure right here? Forget the mass, but like the lateral ventricle. So this is like the opening. So like this is kind of originating out of your left. So this is the distal part of the lateral ventricle that's still open. Your corpus callosum is this structure. Yes. But within the inside is the lateral ventricle. Okay, so you have this tumor, and it kind of looks like jello. So this is a characteristic gross appearance of this type of tumor. And it's an oligodendroglioma. So if you have something, so if I saw something like this, I would either be thinking oligodendroglioma or cryptococcus, because it kind of causes that type of wet look. And the cool thing is, histologically, they call these like soap bubbles, and it looks like cryptococcus does. The whole vacuolated component. So I don't know, I just think that's kind of cool. But going back, so your brachycephalic breeds are more commonly get CNS tumors. It commonly occurs when they're younger than when they're older. Okay, and so this is just one of the CNS tumors they can have, and this one just happens to have this characteristic gelatinous appearance. But what is the most common brain tumor? Does anyone know? Meningioma. So meningioma is the one you're going to see most commonly. Most meningiomas are benign, but because of where they are, they can cause serious problems. But if you can get access, they can be amenable to surgical excision, and the animal will be fine. But of course, you know, your neurons are considered to be terminally differentiated structure, organ, or cells. So if you wait too long and the damage is too severe, they're not going to be able to repair themselves. So if you catch it early, you can be good. So that's the most common. What are your other glial tumors? So we know oligodendrocytes cause oligodendroglioma. So astrocytoma. You can have a microglioma, but those two are probably the most common. I'm going in my brain now, thinking what else there is. There's another, but it's not coming to me. Yeah, so astrocytoma, oligodendroglioma, meningioma, those are going to be the most common. There's something else, but it's not working. You can have, what structure would be hanging right down here? Pituitary, so you get pituitary adenomas. In horses, they characteristically get a pituitary tumor. Y'all know what that is? Yeah. So the PPID, pituitary pars intermedia dysfunction, and you get tumors, usually adenomas within the pars intermedia of the pituitary, and it causes what clinical syndrome? Yeah, equine Cushing's. But remember, equine Cushing's really isn't Cushing's. It doesn't have anything to do with the adrenal gland, but the pars intermedia can secrete ACTH, which is why you get, that's one of the reasons you get the Cushingoid syndrome or signs and the elevation, but also it actually just kind of compresses on your hypothalamus and the pituitary, and that also causes some of the clinical signs you see. And what's the most common clinical sign, or the first thing you usually see with equine Cushing's? Hirsutism. Hirsutism. Y'all have been working.
We got a test on it yesterday.
Very good. So what class? Oh, y'all in endocrinology? Y'all in endocrinology?
Yes.
Oh, good. Who teaches that? Dr. Graham? Like, she knows too much. Okay. So moving on. All right. So dog. Does anybody have an idea of what this could be? So they're sebaceous glands of the eyelid. They just have a different name. Meibomian gland. So meibomian. Did you have a question? Oh. So meibomian gland adenoma, usually benign, and you'll see it right along the eyelid because that's where they are. And histologically, so this is normal sebaceous gland. Looks like any other sebaceous gland. And this is a neoplastic sebaceous gland. This one has, so they can vary in their degree of differentiation. So this has some very well differentiated components and some less differentiated components. But it was still benign, encapsulated, expands out. Yes, sir.
Can you go back 2 pictures? That one right there.
Mhm.
Okay, so you see the one at the bottom?
Yep.
How can you differentiate that from actually being a cherry eye?
because you don't wanna take the meibomian gland out.
They have lots.
So how would you differentiate the
Well,
growth?
cherry eyes, isn't that just a prolapse?
So your nictitane's membrane is right here, so that's still intact. So this is just like right on the eyelid.
Okay.
Yeah. But that's a good question. Yes.
Can you just push the cherry eye back in and not push this thing back in?
I would think so. That sounds good to me. I'm not sure. Anybody know? Y'all physician people. Yeah. So you can, like, yeah, that would, I guess that would make sense. Cause this is like a tumor of the eyelid, like the surrounding haired skin.
Yeah.
So yeah, very good. Yes, ma'am.
So this is normal?
No, that was normal.
This now.
Yeah. So normal, these are all very well differentiated cephophytes with a peripheral basal cell population. And this is kind of a mixture of that basal cell population and well differentiated cephophytes. But there are no features of malignancy. Okay. For some characteristics, modified sebaceous glands of the eyelid. They kind of are all along the eyelid. But they're well demarcated, can go deep in the tissue, and sometimes they can appear dark. And histologically, you can see like pigments within the cytoplasm, so that's not uncommon. So can anybody tell me where we are? What's that?
That looks like eye.
Larynx. Yes. So this is the endotracheal tube.
Oh.
Here's your like your epiglottis,
Oh,
and
that's
it's
what
going
that
into
is.
the
Okay.
trachea.
Looks so weird.
So here's your laryngeal muscle. And this is a tumor